Thank you all for including me in this. It's a pleasure to talk to you and hopefully enlighten you quickly on the management of carotid occlusive disease. I'm going to focus on the surgical approach, but then certainly try to give you a little bit of background in terms of the disease process and the way we think about managing the problems associated with stroke. So stroke is the varying somewhere between the third and the fifth leading cause of death in the United States, but it is the major cause of disability, costing in the somewhere around the $53 billion a year range. There are over 700, more likely 850,000 strokes. The numbers kind of go up and down depending upon people's diets, actually. But the annual stroke rate is about 2 to 5%. And unfortunately, 30% die, 30% are severely disabled. And the most common etiology for a stroke, 20 to 30%, is secondary to carotid stenosis. And what happens after an embolus flows from the carotid artery up into the internal carotid circulation in the middle cerebral is you get complete occlusion of the middle cerebral, and you can either get a wet infarct like this, where there's a bleed into the ischemic cavity, or you can have a dry infarct, which eventually becomes a cavity over time in the middle cerebral distribution. Just wanted to remind everybody about the origins of the carotid. The right carotid comes off the subclavian, the left comes off the aortic arch. Both vertebral arteries come off the subclavian and go up. The anterior circulation is formed by the carotid arteries with the anterior cerebral and middle cerebral, and then the circle of Willis communicating with the posterior circulation and also the anterior communicating artery. And many of you know that the most common location for a stroke is going to be in the middle cerebral distribution. This is a figure demonstrating the vascular supply to different regions of the brain. Obviously, the middle cerebral artery supplies, as you see here, the frontal and temporal portions. The posterior cerebral artery supplies the inferior temporal lobe via the posterior temporal branch and also the occipital branches. The anterior cerebral supplies the medial portions of the frontal lobes back to the parietal lobe. And don't forget about the anterior choroidal artery, which, I always use the mnemonic as one of my PIM questions. Is what does it supply? It's PLOAC, it's PLOAC. So it's the posterior limb of the internal capsule, which is motor, optic radiations, amygdala, lentiform nuclei, and choroid plexus. So very important structures supplied by the anterior choroidal if you have an embolic event in those areas. What is going on in the process of atheromatous disease is there's lipid deposition predominantly within the tunica media. And with that lipid deposition, there can also be adhesions of platelets forming a mural thrombus, and as a result of the mural thrombus, you can either have embolic events which go distally, or you can end up getting complete occlusive disease. And with the occlusive disease, you can also rarely have a distal emboli from the thrombus that forms within the internal carotid artery. The most common regions for atheromatous and then mural thrombi is going to be in the common carotid artery, right at the bifurcation, forming the internal carotid artery and the external carotid artery. Another common area is in the vertebral basilar confluence and at the basilar apex. You'll all remember moya moya. We do see disease in the cavernous segment and the proximal internal carotid wall. This is what you see looking at a vessel in a patient that has severe atherosclerotic disease. And when you look at the wall, you see that the internal elastic membrane with the formation of a thrombus actually stays intact, but with the atheromatous disease, you get lipid deposition within the myointima. The adventitia, the third layer of the vessel, stays relatively intact. An embolus, this is an example of an embolus in a distal vessel, the superficial temporal artery. And again, you can see that the basement membrane here remains relatively intact. This is an acute episode, so the intima, the media, the muscular component doesn't have lipid deposition in it, and you don't see swelling of the cells, and the adventitia appears to be relatively intact. After an infarct, there's the acute occlusion, there's the swelling of the neurons, the dissolution of the nucleus, where you see the Nissl substance break up, you see the nucleolus shrink, and eventually the caspase system and secondary injury starts. And after that, within about 12 hours, you start to see the infiltration of neutrophils, and sometime thereafter, you start to see the infiltration of macrophages to clear out all the debris and dead cells. I just want to remind you all that when a patient presents with a stroke, I mean, the first thing we think about is not necessarily carotid occlusive disease. You've got to start thinking about the origin, and so you worry about the heart, so the patient has to get an ultrasound of the heart and a Holter monitor to make sure that there's no irregularity. Atrial fibrillation is obviously a common source of mural thrombi in the atria, and then distal embolization, hence getting the echocardiogram. You always get an ultrasound of the carotid arteries, and then you want to look at the cerebral vessels. But then one has to think about, congenital problems. Could a person have Moyamoya disease? Could a person have Takayasu's disease or some inflammatory process, some autoimmune process? So you have to maintain an open mind and have a relatively broad differential diagnosis. Certainly, when it comes to taking the boards and/or making rounds on the service, it's always good to go through. Was there a history of trauma? Was there a dissection that led to a mural thrombus and then distal embolus? Is there a congenital problem? Is there an autoimmune disease? Is there a cancer? There are certain cancers that are associated with hypercoagulable states. So learn how to think generally and then apply it specifically to the disease process that we're talking about. One of the major problems with stroke is that they usually, for some reason or other, seem to occur at night while a person's asleep. And for that reason, very few people get to the emergency room in time. And even though we've had this huge push, a robust stroke center like our place, we're only seeing maybe 50 patients a month. Well, you know that there are many more strokes occurring than that. And what was absolutely astounding was during the COVID crisis, our stroke prevalence in the emergency room plummeted. So we suspect that a number of people were just staying at home with their TIAs and minor strokes. And the relevance to this is obviously for the individual. We have to start treating them with TPA within 3 hours and preferentially with intraarterial therapies within 6 hours. If a person has had a TIA, when you see them in the emergency room, they're going to ask you, well, what's my risk for having a stroke, within the next month or within the next year, and on average. And you can see here that once a person has had a TIA or a minor stroke, the first month, their risk ratio goes up 12-1, and over a year, 4-1. And on average, the annual stroke rate for a person that's had a TIA is about 7% per year. What are the treatment modalities for stenosis? It's surgical, and within surgical, I include endovascular therapy, and I'll talk briefly about that. I was asked predominantly to speak about carotid endarterectomy, but then there's medical therapy, and medical therapy now is beyond antiplatelet therapy. It's also the statins, and that's the focus of the CREST-3 trial is more aggressive management in patients with moderate and severe carotid occlusive disease. And we'll wait and see. I personally feel that in competent hands, the risk of doing stenting or an endarterectomy is so low that it's going to be very difficult for medical management to beat the eventual outcomes of surgical intervention. And this was shown way back in 1995 and 1998. The European trial corroborated the NASA trial, which showed that for patients with greater than 70% stenosis, there was a sharp breaking point between the advantages of surgery and medical management. There was a significant reduction in the risk for having major stroke or death in patients that were treated surgically versus medically. In the NASA trial, the reduction was 17%, reduced from 26% down to 9% in patients that were treated surgically. The benefits after 2 years, you can see, are significant, from 26 down to 9. After 5 years, in the 50 to 69% range, there is also some benefit. So patients that have either minor symptoms, TIA-like symptoms with 50% stenosis, what we will probably do in that population is do transcranial Doppler and look and see whether they're having an increased incidence of embolic events. And that patient we would consider strongly for some either endovascular or surgical intervention. This is just a Kaplan-Meier curve, again, demonstrating the significant benefit of surgery in the 70 to 99% group, and also a significant benefit in patients with 50 to 69%. Corroborated by the European carotid trial, similar reduction from 17% down to 4.5%. So significant benefit to surgical intervention for carotid occlusive disease. And this led to the way we basically manage things now. In a patient that's symptomatic with greater than 70% stenosis is going to get a CEA or stent, depending upon their medical comorbidities. Patients with 50 to 69%, we have a debate, less than 50% with medical management. And I want to remind everybody of the ACAS, which is the asymptomatic carotid study, which showed that there was significant benefit for men with carotid stenosis. Why better in men than women, we don't understand. But it was also different in that it was the significance started at 60% stenosis. I am finding that the neurologists are less willing to allow us to operate on patients with 60% stenosis, but this was a very well-run study, and it clearly showed significant benefit. And I think that if you are working in an area where your surgical morbidity is less than 1%, and I've never lost a person with a carotid endarterectomy, so mortality, I think, should be virtually negligible. You can certainly make a strong argument with the neurologist that you might want to treat a patient with this degree of stenosis. How do we evaluate patients? Well, this is kind of a summary of everything that we have done in the past. We don't do angiography anymore. We still do carotid duplex. I know vascular surgeons will operate on the basis of this data alone. I don't. I want to add carotid Doppler with either an MRA or a CTA, and rarely do we use the platelet scintigraphy anymore. So it's predominantly a Doppler study as a preliminary, and then either MRA or CTA. Here's an example of an angiogram that shows a nice ulceration within the plaque. There are studies, and there's the SUNT classification, A, B, and C, depending on the extent of the plaque and the degree of ulceration, C being the worst. Again, another argument for a patient that might not have totally severe stenosis, but they've got a really ratty or irregular stenotic lesion with a big ulceration. There you might push your neurologist to do transcranial Doppler to see whether there are increased embolic events. This is an example of an MRA, and one of the disadvantages of MRA is that you get flow dropout when the degree of stenosis is greater than 90%, so you don't have a really good sense for how bad it is. With the newer imaging, they can tell you whether this is calcification. We can do a wall study to see how much of it is inflammation and how much of it is soft plaque and how much of it is calcified plaque. And then this is the CTA. I personally prefer a CTA because it really looks at the dye column, and you're seeing dye within the vessel, and you can do different shadowing and certainly determine whether it's a calcified plaque. And understanding whether it's a densely calcified circumferential plaque is important when one is deciding whether to do a stent procedure versus a carotid endarterectomy. As I had shown in earlier slides, the area we're worried about is the carotid bifurcation. There's turbulence of flow. The turbulence of flow induces injury and the deposition of lipid and the formation of platelet aggregates, which can cause the distal embolic events. The procedure is done with the patient. Some surgeons will do awake. I prefer to do it with the patient asleep because it's a teaching hospital, and I'm not sure that patients would really want to know that I'm, taking a resident through it. There's intraoperative monitoring with EEG. I do not use a Foley. We have arterial lines, and that's all the monitoring that we do. And basically, there's a little roll placed onto the shoulder, and the head is placed on a donut so that we have access to the neck. The incision is made centered over the angle of the mandible. The angle of the mandible usually is a bony landmark for where the bifurcation occurs. But when you're looking at your CTA, you can determine whether the bifurcation is at the angle of the mandible or below it. And usually, I should say, it's at the hyoid bone, which is below the angle of the mandible. When the plaque goes above the angle of the mandible, it becomes a little bit more of a surgical challenge. A linear incision is made along the medial border of the sternocleidomastoid muscle, and then down. You go down the medial border of that muscle, and you identify the internal jugular, the jugular vein. Up higher, you see the spinal accessory nerve coming out from underneath the digastric muscle. This is the parotid gland up here, and you can see the carotid artery here. And in the neck, the external carotid artery is medial, the internal carotid artery is lateral, and this is the hypoglossal nerve, which you can see more clearly here. And the one landmark that is really true is that the common facial vein is a great landmark for the bifurcation. This has to be taken via suture ligature, so you can access the common carotid artery, external carotid artery, internal carotid artery, and this is an unusual low-lying hypoglossal. More commonly, you will find the hypoglossal laying up underneath the digastric, so it's not in your way when you're doing the endarterectomy. This is with the jugular vein reflected medially. That's not what we do in the operating room. In the operating room, we isolate the common carotid artery, external carotid artery, internal carotid artery. Obviously, you know the external carotid artery by the branches that come off it. The first branch that comes off is the superior thyroid. There are no branches on the common or internal carotid artery. And we isolate the vessels, placing umbilical tapes around the internal and common carotid artery, and we can't put one around the external. And I put a vessel loop around the superior thyroid artery so that we can loosen it up in the end and allow for a little backflow while we're finally closing the arteriotomy. This is called a Ramel tourniquet, which is a red rubber tube that is slid down over the umbilical tape, and that is cinched down in patients that require placement of a shunt. That the need for a shunt is determined on the basis of the EEG. If the patient's EEG goes flat, we then put a shunt in. You slide it into the distal end first, tighten down the Ramel tourniquet, and then you slide it into the common or carotid artery. Obviously, you have to take off the clamps, and there's a little bit of bleeding during that episode. we don't have to worry about the external carotid artery. This is an example of the Argyle shunt. We put a suture in the middle of it so that we know exactly where the middle of the shunt is, so we don't slide it either too high or too low, and we make sure that we get flow in the appropriate region. So I'll take you through some slides. As I said, there's an oblique incision. We isolate, we put the umbilical tape around the common carotid artery. The vessel loop is around the superior thyroid artery to provide traction. This is the external carotid artery, which is medial. We'll put an umbilical tape around that. And then the internal carotid artery is down here. You can see that we've got the vessel loops around it. What I've done is I've marked where we're going to make our arteriotomy. It extends from the common into the internal. And you can feel with your finger where the plaque ends, but also you can see that the vessel goes from being a little bit whiter from the plaque and it pinks up beyond the distal end of the plaque. We put the bulldog clamp on the internal carotid first so that as we're manipulating the vessel, nothing flies up into the brain. Then we put a DeBakey clamp across the common and finally put a clamp across the external carotid artery. An arteriotomy is performed initially with an 11-blade knife and then extended with pot scissors. And then we dissect out the plaque in a circumferential fashion, and then we close the vessel. And this is what it looks like when we're done. This is what the plaque looks like. And I'm going to show you, this is a video that if you go into operative, neurological surgery, the Dick Wynn book, in my chapter on carotid endarterectomy, there's this video, but we'll play this. It's only 3 minutes.
Steps of the procedure. What we do is put intraoperative EEG electrodes on the scalp, and then general endotracheal anesthesia is induced. And we have a baseline EEG. Thereafter, the patient is induced with general anesthesia. The roll is placed under his shoulder, and his head is placed in a donut and rotated approximately 15 degrees to the contralateral side of the surgery. We then make an oblique incision along the medial border of the sternocleidomastoid muscle, taking the dissection down to the common facial vein, which is taken by a suture ligature. We then deepen the dissection to identify the common carotid artery, which is isolated with an umbilical tape, the external carotid artery isolated with an umbilical tape, and the superior thyroid artery isolated with a vessel loop, and finally the internal carotid artery, and in so doing identifying the hypoglossal nerve, which in this case was at the superior aspect of the dissection. Once we have adequate exposure and hemostasis, Ramel tourniquets are placed on the common and internal carotid vessel loops, and then the patient is given 5,000 units of heparin. After 3 minutes, the first bulldog clamp is placed on the internal carotid artery to isolate circulation and to prevent any distal emboli from flying up into the brain. And then simultaneously, a DeBakey clamp is placed across the common carotid artery and another bulldog clamp across the external carotid artery. An arteriotomy is performed with an 11-blade knife initially in the common carotid artery and then extended with pot scissors into the internal carotid artery past the plaque. We then do a circumferential dissection using a number 4 Penfield dissector around the plaque in the common carotid artery, placing a right angle dissector under the plaque and cutting the plaque sharply with a 15-blade knife. We then evert the plaque to the remaining portion of the common carotid artery, as well as the external carotid artery, and then feather it out of the internal carotid artery. In this case, there was still a little free fragment of plaque, which required a tacking suture using a double-arm 7/0 proline, and that held the plaque down. We then close the arteriotomy using a double-arm 6/0 proline, going from internal to external and running it from distal to proximal, and a second double-arm 6/0 proline, running it from proximal to distal. Prior to complete closure, we irrigate with heparinized saline and also allow for retrograde anterograde bleeding to make sure there are no other free fragments, and then close the arteriotomy. I then allow for several pulsations from the internal carotid artery, replacing the bulldog clamp, and then open the common and external carotid arteries simultaneously, allowing 10 pulsations, and then opening the internal carotid artery. We then assess flow with a Doppler, and at that point, we make sure that the entire operation is hemostatically dry. If there were a leak along the arteriotomy, we would close it with a figure-of-8 7/0 proline. In this case, that was not needed. Once hemostasis is achieved, the wound is closed using 3/0 Vicryl in the platysma and a 4/0 Vicryl subcuticular stitch.
So that's a 3 minute description. The endarterectomy itself takes about anywhere from 15 to 30 minutes to do, from the arteriotomy to closure. Most of it is most of the time in the surgery, which goes about an hour and a half to 2 hours, is in taking the resident through, getting down and dissecting down into the neck. After, I used to do an intraoperative angiogram where we would just put a little angiocath in and then inject some dye. I've deviated away from that. The more common area for a mistake was actually in the distal vessel when you feathered the plaque out. And the angiogram is a little bit difficult to interpret because there's a fair amount of spasm in the vessel. So I didn't feel that it was of great benefit. On occasion, we will use something called a patch. I like to use a Dacron patch because it doesn't keep holes in it, and I don't have to harvest the saphenous vein and make another incision. These are examples. This is the saphenous vein. This is the Dacron patch, and you can see it has a nice line, so you can line it up. And the indications in my mind for using these patches is when the distal vessel is very small, i.e. less than 2 millimeters in size, where we're opening up a string vessel. If you look at the national statistics on mortality, and that, this is where the neurologists get all excited. They say the mortality is 2.3%, and I don't, I don't dispute this. I just think that, I've not had a mortality. Have I had a neck hematoma? Sure. I've not had a seizure. The things I actually worry a little bit more about is, traction on the hypoglossal nerve, so they have a little bit of tongue weakness, and then obviously having and some kind of a TIA or embolic event while you're doing the procedure. With carotid endarterectomy, the risk is actually greater for having a heart attack than it is for having a stroke. So all of my patients, I get evaluated preoperatively by our cardiologists, and that was the difference when they looked at endarterectomy versus stenting. This, I just want to say, is the article that I was referring to in '95 with ACAST, where asymptomatic carotid stenosis of 60% showed that it was beneficial. You can look these all up. That's why I put the abstract and the titles in for you. The asymptomatic embolization for prediction of stroke talks about the use of transcranial Doppler to predict who might be at higher risk, even though they don't have severe carotid stenosis. This is an example of a patient who obviously didn't make it in time for their carotid endarterectomy, and you can see here that they have a high-grade stenosis right here, and then they have a string sign, going up distal to the internal carotid artery. And they presented, this is on the right side, presented with left-sided weakness and an NIH stroke score of 14. You know that 0 to 1 is the best. The higher you go, the worse. And after this was a patient that underwent an embolectomy. To do the embolectomy, they have to do balloon angioplasty, which improve the flow in the internal carotid artery. But you can still see that there was this local dissection here at the origin of the internal carotid artery. So a stent was placed across the origin, and now you can see that the vessel is acutely dilated. And with the embolectomy, we've taken it from a string sign with no flow to a completely patent middle cerebral artery. The patient was discharged in postoperative day 3 with an NIH stroke score of 1. There has been a lot of debate about endarterectomy versus stenting in patients with severe carotid stenosis. They're probably at equipoise, I think, in terms of the utility. I will say at our institution, we're doing more endarterectomies than we are stents. We reserve stents for patients that have a significant number of medical comorbidities, such as heart disease, cancer, or in patients that have had radiation to their neck and they've got stenosis of their carotid artery, that stenosis is usually related to myointimal hyperplasia, and it's a smooth stenosis, and we can get a very nice dilatation with the balloon and treat it with a stent. Plus, we don't have to operate on a vessel that's been radiated and stuck to everything around it, where you increase the risk of lower cranial neuropathies. When we looked at CEA versus stent in symptomatic stenosis greater than 60%, the 30-day risk of stroke or death with carotid endarterectomy is about 4% and about 10% with the stent. And that's why we have now leaned more towards the CEA for carotid stenosis. That being said, there's an increased risk for having an MI, but I have found that we can alleviate that risk by aggressive preoperative evaluation and medical management. The 30-day risk of disabling stroke or death with CEA is 1.5% versus stent 3.4%, and the relative risk is 2.2. So with that, as I said, we've leaned more towards stenting. I can envision a day when we're also doing more stenting for carotid endarterectomy. Let's face it, everybody wants something that's minimally invasive, and it's certainly more desirable. But that being said, my patients with carotid endarterectomy leave the hospital the day after surgery. So the length of hospitalization is essentially the same as well. So with that, I will say thank you, and open the floor to any questions that have come to Michael or that I can answer for you. Thanks so much for letting me speak.
Hey everyone, Ryan Rad here from Neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.